good afternoon, and welcome to today's Internal Medicine Grand Rounds. There is no commercial support. The speaker and planners have disclosed no relevant financial relationships with any commercial interests. You will receive a SurveyMonkey link after today's activity, and if you're viewing online, we will list that into the chat section of the Zoom. If you have a question, we'll ask that you hold it until the end, and we will, if you're viewing online, we will ask that question for you. Just enter it into the chat section. It is my pleasure to introduce Dr. Hossny Alaws. Dr. Alaws is originally from Montreal, Canada. He attended medical school at the University College Cork School of Medicine in Cork, Ireland. He is pursuing a fellowship in pulmonary disease and critical care medicine at the Mayo Clinic in Jacksonville, Florida.
Hello, everyone, and thanks for coming. So today I'm going to be talking about ARDS, or acute respiratory distress syndrome. I'm going to be talking about two particular things. The definition, which is there's a new definition that was published in the ATS in 2024. I'm also going to be talking in detail about management strategies and the evidence behind them. New management strategies in 2024 that was also published in the ATS. So here's an overview of my presentation. So first I'm going to talk a little bit about a history of ARDS. I'm going to talk about some old definitions throughout the years, and then I'm going to delve into the new definition that was proposed, building on the old definitions. Talk about the pathophysiology, some imaging examples, and some etiologies. And finally, I'm going to talk in detail about the new management strategies that were proposed in 2024. And in the end, I'm going to summarize and talk about areas for further research. So we'll begin with a case. This is something we've seen over and over again, but say you're a hospitalist rounding on a patient. He's 68 years old, presented to the hospital 2 days ago, and he was presented with worsening shortness of breath for 4 days, cough productive of green sputum, vital signs showed fever of 39, he was tachycardic, he was hypoxic, 86% on room air, and now he required 4 liters on admission to get his SpO2 up to 93%. On examination, he had crackles at the left lung base. His labs showed leukocytosis of 15,000, and this is his chest X-ray. So you guys see the arrow here. There's some kind of left lower lobe consolidation. So this is kind of a common presentation of community-acquired pneumonia. And so the patient was diagnosed with community-acquired pneumonia, admitted to the hospital, and at our hospital here, we would treat that with ampicillin, sulbactam, and azithromycin. Now he's 2 days into the hospital admission. You're rounding on him, and you look through his chart in the morning, and you see that he's on 30 liters for high flow nasal cannula. You talk to the patient, he says he's short of breath, he looks in distress, and either while you're in the room or sometime later on, the nurse messages you that his oxygen saturation has dropped to 85% on 30 liters, and now he had to be increased to 40 liters and 100% FiO2. And his SpO2 is 92% on that oxygenation. Does that patient have ARDS? Well, we're going to try to answer that question. But first, what is ARDS? Well, ARDS, if I had to put it in one kind of sentence, and we'll delve deeper into different definitions, but it's a clinical syndrome of acute hypoxemic respiratory failure due to lung inflammation not caused by cardiogenic pulmonary edema. That's in a nutshell what ARDS is. So this is kind of the history of ARDS. The first time it was described was in 1967 by Ashbaugh et al. But the first definition didn't come out until in the 1980s, 1988. And at that time, Murray et al. Came up with this thing called the lung injury score, and that was the first kind of diagnostic criteria they put forth. It's pretty similar in some ways to the diagnoses we use, but there are some key differences. They required basically chest radiographic changes, P to F ratio, and but they also included some other things that we don't use today, like lung compliance for defining ARDS. That definition was revised in 1992 by the American Thoracic Society and European Society of Intensive Care Medicine, and they proposed similar criteria but more detailed, like acute onset, chest radiograph showing bilateral infiltrates, and no clinical evidence of left atrial hypertension, meaning no evidence of heart failure causing the symptoms, and a P to F ratio of less than 200. That definition was there until 2012, where the Berlin definition came into play, and that's the definition I learned. That's the definition we've been using for a while, until 2024, when a new definition, which is similar but has some key differences, was proposed. So the Berlin definition was proposed by the European Society of Intensive Care Medicine in 2012. They convened in Berlin and they came up with its definition. So this is kind of the diagnostic criteria by the Berlin definition. Bilateral opacity is not fully explained by pulmonary edema. Timing is 1 week or less since new or worsening respiratory symptoms and a known clinical insult. And oxygenation with P to F ratio. So the P to F ratio, they characterize it as mild, moderate, or severe based on the P to F ratio. And key or crucially, they required a PEEP of 5 centimeters of water or more. So you had to be either intubated or not on non-invasive ventilation to qualify for ARDS diagnosis. But the Berlin diagnosis was great, the Berlin definition, but it had some limitations. So first of all, like I said, it requires non-invasive ventilation or invasive ventilation with a minimum of 5 centimeters of PEEP. Second, it required ABG and a P to F ratio. So you need to get an ABG, which sometimes could be hard to get in an emergent situation, can be arduous, or can be not available if you lack resources. And then the third thing is it didn't really comment on high flow nasal cannula as a oxygenation modality or oxygen delivery device. But since 2015, really, that the use of high flow nasal cannula has increased significantly. There was one trial called the Florali trial published in 2015, and it compared high flow nasal cannula versus non-invasive ventilation versus standard oxygen. And it showed that in patients who only have acute hypoxemic respiratory failure, so no hypercapnia, high flow nasal cannula reduced ICU mortality and 90-day mortality compared to non-invasive ventilation and compared to standard oxygen. And the last limitation of the Berlin definition is something also I touched on, which is it can be limited in resource-limited settings, which don't have maybe CT scans or chest X-rays. Maybe they don't have mechanical ventilation or ABGs. So for those reasons, a new definition was proposed in 2024, published by the ATS. This slide here kind of shows a table of all the different diagnostic criteria, and they're similar to Berlin in a lot of ways, but there are some crucial differences. We'll go through those. But they kind of put forth a conceptual model, which basically is like a textbook definition, which is ARDS is an acute inflammatory lung injury precipitated by a predisposing factor, risk factor, which we'll talk about those in a minute, and leads to increased vascular and epithelial permeability, lung edema, and decrease in aerated lung tissue. The clinical hallmarks are hypoxemia and diffuse radiographic opacities and decreased lung compliance. So, with that in mind, the diagnostic criteria for the new global definition published in 2024 is risk factors have to be present, which again, we'll go in detail into them, but some examples are pneumonia, trauma, transfusion, aspiration, shock. Timing has to be acute onset of respiratory failure or worsening respiratory symptoms within the last week. And again, that's similar to the Berlin criteria. Chest imaging, though, has a crucial difference. It says bilateral opacities with chest radiograph or computed tomography, but you can also use ultrasound as an imaging modality. And if you have bilateral B lines or consolidations on ultrasound, that fits the chest imaging criterion for the new definition. And then lastly is the oxygenation criterion, and that also differs from Berlin in the sense that they added two different categories, or three, sorry, non-intubated, intubated, and resource-limited ARDS. So the intubated ARDS is essentially the same as the Berlin criteria, mild, moderate to severe based on the P to F ratio, but they also added the SpO2 to FiO2 ratio as a alternative to P to F ratio. So what I mean by that is you don't need an ABG, you can rely on SpO2 if the patient's SpO2 is greater than 97% on 30 liters or more of high flow nasal cannula, or the equivalent with invasive ventilation. The other criterion is non-intubated ARDS, and that's also a key difference here, which is essentially you don't need to be on mechanical ventilation or non-invasive ventilation. You can just be on high flow nasal cannula at least 30 liters per minute with an SpO2 of 97%, and you can also use the SpO2 to FiO2 ratio. And so the cutoffs they used here are for mild 315 SpO2 to FiO2 ratio, for moderate between 148 to 235, and for severe SpO2 to FiO2 ratio less than 148. So those kind of are numbers you can remember for diagnosing. The last thing that differs as well is the modified definition for resource-limited settings. So in resource-limited settings, you may not need high-flow nasal cannula. You may not have chest X-ray or ABG. You can use SpO2 to FiO2 ratio, and you can also use things like a non-rebreather mask or something like that to diagnose ARDS. So this table kind of summarizes all the key differences and compares the Berlin definition to the old one, but I'm just going to highlight the differences here. So high flow nasal cannula was included, at least 30 liters per minute. Ultrasound can be used as an imaging modality with the caveat that the ultrasound operator has to be experienced in ultrasound. S to F ratio, SpO2 to FiO2 ratio can be used. Non-intubated patients on high flow nasal cannula can be included in the definition. And in resource limited settings, a high flow nasal cannula is not even required. P to F ratio is not required. You can use something like a non-rebreather. So here are three patient kind of vignettes that illustrate this definition. So the top one is basically the classic Berlin definition that we've seen before. An intubated patient with septic shock and acute respiratory failure. He has these imaging findings, and his P to F ratio is 150. That's intubated ARDS with moderate severity. It's basically the same as the Berlin definition. Here, though, it's a different patient. It's a 54-year-old female with a history of breast cancer, COVID-19 pneumonia, and worsening shortness of breath for 6 days. Her chest X-ray findings are here, and she's on high-flow nasal oxygen, 40 liters a minute, with an 80% FiO2. So that patient also meets the non-intubated ARDS criteria because she has worsening symptoms for 6 days. She has an injury, which is COVID-19 pneumonia or insult that's known. She has bilateral diffuse lung disease on chest X-ray. And her SpO2, the FiO2 ratio, is 114. And so that meets the cutoff of 315. So the last patient vignette is, say you have a 39-year-old female with abdominal sepsis and gram-negative bacteremia in a small, under-resourced hospital. There's no blood gases, there's no radiography, there's no high-flow nasal cannula. What you do is you get an ultrasound, and this is what it looks like. And then she's on 15 liters nasal mask, non-rebreather mask. Her FiO2 is calculated at 60%, and her SpO2 to FiO2 ratio is 142. And if you see here, the ultrasound shows basically B lines, these like little things going down bilaterally. And so that meets the imaging criterion for ARDS. So this patient meets the ARDS in a resource-limited setting definition criterion. So we are missing a slide here, but that's okay. If we go back to our patient, if you remember, he was on high-flow nasal cannula, 40 liters a minute, 100% FiO2, and his chest X-ray showed, let's say you got a chest X-ray and shows bilateral infiltrates. Does he have ARDS? By the Berlin definition, no. But by our definition, by the new global definition that we just proposed here, he would have ARDS. So, gonna go a little bit more into ARDS as an entity. So talk about some etiologies. So you can have direct and indirect etiologies. This is not an exhaustive list, but something like pneumonia, sepsis, trauma, inhalation, transfusion-associated lung injury, drowning, pancreatitis, hemorrhagic shock, burns, reperfusion injury after embolectomy, all these things can lead to ARDS. So as you see, there's an exhaustive list of etiologies. A little bit about the pathophysiology. This slide kind of illustrates it. So you have some kind of an injury that we described before. This injury leads to inflammatory response at the level of the alveolus. So if you see here, for example, this is an alveolus and this is a capillary here. So this is the alveolar capillary epithelium. And you have some kind of an injury here that leads to recruitment of inflammatory cells to repair the injury. And that includes macrophages and T cells. These T cells and macrophages release multiple cytokines and chemokines and inflammatory mediators. For example, metalloproteases, elastases, all of these lead to a breakdown, damage to the epithelial barrier. This damage leads to leakage of protein-rich fluids filled with inflammatory cells, and that leads to mechanical stretch, more injury, and a cycle of injury and inflammation. All of this, the end product is a VQ mismatch, and that is caused by two mechanisms. A, the alveoli get filled with fluid, and they're not available for oxygen exchange. And B, all these inflammatory mediators lead to, they're prothrombotic, and they lead to microthrombi that decrease perfusion. And so that leads to dead space ventilation, which is basically alveoli that are ventilated but not perfused. So this leads to hypoxemia and all the effects that we're going to talk about. Now, this is, as you see, like an inflammatory cycle, and the way to treat ARDS is to support the patient, support their body, and try to prevent them from basically dying while their body repairs this injury. And that could take a long time, but over time, the epithelial integrity is reestablished and the alveolar fluid is absorbed. But sometimes that can, this injury and inflammation can lead to fibrosis, and that can lead to its own slew of issues. And we've seen that a lot during the COVID pandemic. To anybody who's been through the pandemic, we've seen a lot of ARDS and patients having fibrosis. Some imaging examples of ARDS. So there's a million examples you can find, but these are just two panels that illustrate. So this is a chest X-ray here of the same patient with progression of disease. You see the chest X-ray looks pretty clear, but then as you go to B and C, you see more diffuse bilateral airspace disease and alveolar infiltrates. And then D here, that leads to the lung whiteout that we see in ARDS patients. On the right side, you see a CT scan, a transverse section of a CT chest. And you see that there's, again, bilateral disease. You see that there's more, this is more heterogeneous, but definitely diffuse and bilateral. You see that there's an effusion here, there's some infiltrates here, but there's also some ground glass opacities with interlobular thickening, which is what's called crazy paving pattern. So there's many examples, but the overarching principle in imaging is diffuse disease, basically. So that's what I talked about. Our patient does not, back to our patient, it does not have ARDS by the Berlin definition, but he does have ARDS by the new definition, which is acute onset with a predisposing condition, pneumonia, bilateral opacities on imaging, and he had 100% FiO2, and his S to F ratio was 92 over 100, which is 92, less than 315. So it meets the cutoff for ARDS. So say that patient now, you're the hospitalist and you're seeing this patient, he's getting even worse. He's becoming more and more hypoxic on 100% FiO2. He's increased work of breathing, he's getting altered. And the next step would be to intubate the patient. So he got rapid sequence intubation, was placed on ventilator and transferred to the ICU. Okay, so how would you manage that patient? And that brings me to my next point, which is I'm going to talk about management strategies for ARDS, let's say in the ICU and otherwise, really. So the overarching principle, like I said before, is supportive treatment, letting supporting the patient, preventing them from dying, basically, while ARDS and the inflammation gets healed. But there are various different management strategies you can use in the ICU. So in 2017, some guidelines were published about the management of patients with ARDS. They were joint ATS, European Society, and Society of Critical Care Medicine. These guidelines were used until now, 2024, when there was an update published by ATS, and that's what I'm going to be talking about, the new management strategies for ATS. So there were multiple recommendations in those guidelines in 2017. Some of them are different from the new management strategies, but 3 here were present in the 2017 guidelines and still persist in the 2024 guidelines. And we'll talk more in detail about them, but they include low tidal volume ventilation, prone positioning, and a recommendation against high-frequency oscillatory ventilation. So we'll talk in detail more about each of these. So we'll start with low tidal volume ventilation, that strategy that was recommended in 2017 and still recommended in 2024. So you see here, this table here showcases different ventilation strategies that we trialed over the years in ARDS. So examples are in the 1970s, high levels of PEEP, high-frequency jet ventilation, prophylactic PEEP, pressure-controlled inverse ratio ventilation. So there's different types of ventilation. But over time with experience, we realized that ventilators can cause harm sometimes. And that's through different mechanisms. So the 3 main mechanisms where ventilators cause harm are volutrauma or barotrauma, atelectrotrauma, and biotrauma. Okay? So we'll start with volutrauma or barotrauma. So barotrauma happens when you give a lot of pressure or a lot of volume to patients on the ventilator. And what happens then is that leads to overdistension of the alveoli and mechanical stretch and injury. And especially in ARDS patients who have low lung compliance, they have very stiff lungs in certain areas that are damaged. If you give them extra pressure, extra volume, that can lead to excessive damage in trying to get their oxygen level high. The second mechanism is atelectrotrauma, which is basically if you have an alveolus and every time you exhale, the alveoli collapse completely. What happens then is every time you exhale, they collapse. Every time you inhale, they re-expand. That over time, that leads to shear stress and denaturation of surfactant. And that also leads to lung injury. And the last thing is biotrauma. So both atelectrotrauma and volutrauma, the damage, mechanical stretch, damage of the epithelial barium leads to translocation of inflammatory mediators and leads to multi-organ failure and death. And that's what's called biotrauma. So again, this is a very busy slide, but it illustrates the points that I was trying to make, is that high volume ventilation leads to overdistension of the alveoli and mechanical stretch, including sloughing of the epithelium. And then here you see a collapsed alveolus at the end of expiration, and that also leads to denaturation of surfactant. And here at the bottom you see translocation of things like bacteria, inflammatory mediators, multi-organ failure, and death. So with that in mind, they set out to try to figure out whether low tidal volume ventilation would improve mortality. And in 2000, they published this trial called the ARDS net trial, which we probably have all heard about. It was a landmark trial published in 2000 in the New England Journal of Medicine. And in that trial, they had 861 patients, and they randomized them to one group receiving tidal volume of 4 to 8 cc's per kg of ideal body weight and trying to keep plateau pressure less than 30, versus tidal volume of 12 cc's per kg, trying to keep the plateau pressure less than 50. And they found that low tidal volume ventilation had 9% lower mortality compared with high tidal volume ventilation. So just a few notes about ARDS net strategy that are kind of practical in terms of ventilating these patients. First of all, when you put lower tidal volumes, you're going to have less ventilation and less CO2 exchange. So more CO2 retention, more acidemia. And that's okay. It's okay to have a goal pH shouldn't be really normal. It should be above 7.3. You can increase the respiratory rate to help, but you can also have permissive hypercapnia as opposed to increasing the tidal volume. Second thing is you don't really need normoxemia because, again, the same thing. Normoxemia, if you're really trying to aim for an SpO2 of 100%, you're going to try to increase the PEEP a lot and try to increase the tidal volume a lot, and that may lead to more harm than benefit. So the goal SpO2 should be 88 to 95%, or a PaO2 goal of 55 to 80 millimeters of mercury. The next strategy that they commented on in the 2024 guidelines that was present in the 2017 guidelines is prone positioning. So if you look at this illustration here, it shows why prone positioning may be helpful physiologically. If the patients who are lying supine in the ICU are basically the patient is lying supine, this is the back of the lung, this is the front of the lung, this is the heart. You see that there's more lung in the back, basically. Just makes sense. And so these, when you're lying flat, the gravitational force on your back leads to atelectasis at the bottom and interstitial fluid basically pulling back here. And so you have less lung that's aerated. And also the heart is compressing on the left lung. Whereas if you flip the patients on their front, you see that there's less lung at the front. And the heart is not so much compressing on the left lung, and there's more aerated lung. That improves VQ mismatch. So that's the rationale behind proning. And that was tested in a trial in 2013 called the PROSEVA trial, published in New England Journal of Medicine. And they compared patients who had severe ARDS with a P to F ratio less than 150 within the first 36 hours of intubation or ventilation. And they compared proning versus supine. And they found that proning reduced 28-day mortality by half, 16 versus 38.2%. And also they reduced the 90-day mortality. But as we all know, proning requires an experienced care team because proning patients in the ICU can have a lot of complications, as we've seen during the COVID pandemic. So things like pressure ulcers, extubation, and decannulation. So this just slide here shows how the evidence was basically how did they make the recommendations for strong versus conditional. And to basically summarize it, strong means nearly everyone in every situation would benefit from it. Conditional means most patients would benefit from it, but not everyone, and you need to apply clinical judgment. So with that in mind, we'll talk about the first guideline that differs from 2017 in the 2024 ARDS guidelines. Should patients with ARDS receive steroids? And their suggestion was yes, we recommend using steroids for patients with ARDS. And that was a conditional recommendation with moderate evidence. So steroids, as we all know, corticosteroids, they're anti-inflammatory. And as we just talked about, ARDS is a very pro-inflammatory disease. So it would make sense that they might help. But corticosteroids were not addressed in 2017 guidelines. But since then, multiple randomized controlled trials showed the effect of corticosteroids on ARDS patients. In fact, there was 19 randomized controlled trials, with include 2,790 patients total. And this kind of slide shows the pooled data from these trials. So they pooled the patients together, and they analyzed the trials all together. And they found that corticosteroids probably reduce mortalities based on 17 studies, may reduce the duration of mechanical ventilation. This is based on 9 studies. The pooled analysis showed 4 days less mechanical ventilation. It may reduce the length of hospital stay based on 4 studies with 8 days shorter based on the pooled analysis. But it had an uncertain effect on the length of ICU stay, and it probably increased the risk of serious hyperglycemia, GI bleeding, with uncertain effect on neuromuscular weakness. So again, it had some safety considerations. This slide here shows all the different trials. Actually, it's 2 slides that show all the different trials. I'm not going to go into detail about them, but I just want to point out that the dosing or interventional protocol was very heterogeneous between the two. So you see here like hydrocortisone for 7 days, here methylprednisolone for 28 days, here methylprednisolone for 32 days, here kind of a tapering dose for 14 days, here for 7 days. So you see very heterogeneous protocol. And also the patients that were included in the different trials were also different from each other. So yes, all of them had ARDS, but some included patients with early ARDS with adrenal insufficiency. Some included only patients with severe ARDS. Some included patients with all of ARDS criteria. So the thing about the guidelines is although they made a recommendation on the use of steroids, they did not put any guidance on the choice of steroids, the dosing of steroids, the timing of steroids, or the duration. They just said, we recommend using steroids and use your clinical judgment. And you can use different dosing protocols for certain diseases, like there's COVID dosing protocol. The patient had COVID and then ARDS. There's a community-acquired pneumonia dosing protocol as well. And so you can use those, if you will. That's what they said in the guidelines. The next recommendation deals with VV ECMO or veno-venous ECMO. And the question was, should patients with ARDS receive VV ECMO? And the answer was, we suggest the use of VV ECMO in selected patients with severe ARDS. That was a conditional recommendation with low quality of evidence. So what is VV ECMO? We probably all heard of it. It's veno-venous ECMO, or veno-venous extracorporeal membrane oxygenation. Essentially, simplified diagram here, it's a device that takes deoxygenated blood from the venous circulation, puts it through an oxygenator that oxygenates it, and puts it back into the venous circulation to go back to the heart, lungs, the stomach circulation. The use of VV ECMO really increased in the past few years, especially since the COVID-19 pandemic. The 2017 guidelines did not comment on VV ECMO. They didn't find sufficient evidence, but there's some new evidence that emerged, and I'll talk about it in a second. But a note about VV ECMO, as we all know, it's very invasive, very resource heavy, requires specialized centers, and it has significant cost. So this VV ECMO recommendation came from 2 randomized controlled trials involving 429 patients. The first one had 180 patients, which were either randomized to conventional ARDS management versus VV ECMO with follow-up at 6 months. Crucially, they did not really specify what the management protocol was in the control arm. They're like, just do whatever you would do for ARDS. The second one had 249 patients randomized to VV ECMO versus conventional management for 60 days, but they protocolized the ventilator management, and they used also, or encouraged neuromuscular blocking agents and proning. The pooled analysis showed that VV ECMO probably reduced mortality with a relative risk of 0.76, probably increased ventilator-free days. It had 8 days more ventilator-free, vasopressor-free days, and renal replacement therapy-free days compared to conventional ARDS management. But these patients had severe ARDS. And the safety outcomes, it probably increased the risk of hemorrhage, may have little to no effect on pneumothorax, and uncertain effect on stroke. I can share the studies with anyone who's interested, by the way. But the next recommendation deals with neuromuscular blocking agents, or paralytics. And the question is, should patients with ARDS receive neuromuscular blockade? The answer is, again, yes. They suggested the use in patients with early severe ARDS. This is a conditional recommendation with a low certainty of evidence. So neuromuscular blocking agents, or paralytics, are basically medications that act at the neuromuscular junction to paralyze the patient. The mechanism of benefit in ARDS is not really clear, but there are some proposed mechanisms. Number one and most proposed theorem is ventilator dysynchrony. They help patients who are fighting the vent by paralyzing them. But there's also some studies that suggest reduced inflammation, oxygen consumption, and alveolar fluids. Again, they were not addressed in 2017, but there's been increasing evidence for their use, and that's why they evaluated them in these guidelines. So this graph here shows the difference between a patient who's fighting the vent or dysynchronous with the vent versus a patient who's paralyzed. And here on the left side, you see that the patient this is the pressure gradient on the y-axis. You see the patient here taking a deep breath at the same time the ventilator is given a breath, and vice versa. And so what happens is when the patient is taking a deep breath at the same time the ventilator is given a breath, that leads to higher lung volumes at the end of inspiration. And then at the same time, if the patient is given out a breath or exhaling at the same time the ventilator is exhaling, that leads to lower lung volumes at the end of inspiration. And so that basically leads to the same damage that we talked about before. Increased lung volumes lead to barotrauma, and decreased lung volumes lead to electrotrauma. That leads to more inflammation, worsening of ARDS. Versus a patient here who's paralyzed, not generating any pressure, and the ventilator is just doing its thing, and the patient has normal or low tidal volumes if they're doing a low tidal volume ventilation strategy. So again, this neat kind of physiologic picture here to show the difference between a normal patient breathing like you and I, and a patient who's fighting with the vent. You see, if a normal patient is breathing here, at the end of inspiration, the pressure that the lung experiences is the difference between the pressure inside the lung and the pressure outside the lung. So 0 here inside the lung at the end of inspiration. It equalized with the atmospheric pressure. And -8 here is the pleural pressure. So it's going to be 0 minus -8 plus 8 centimeters of water. That's the pressure experienced by the lung, or the transpulmonary pressure. On the other hand, if the patient is in respiratory distress, fighting the vent, here the pressure experienced by the lung is the transpulmonary pressure, the pressure between the inside the lung and outside the lung. Here, let's say the ventilator gave a breath, 10 centimeters of water, and the patient is trying to take a deep breath at the same time. So trying to expand their lung. So they're increasing the negative pressure here by their muscles. And so the breath by the lung is 10, and then the pressure here is -15 because you're trying to suck air out more. And so the pressure experienced by the lung is the pressure inside minus the pressure outside. Transpulmonary pressure is 10 minus -15, 25. So it just basically shows you that the patient fighting the vent is generating 3 times more pressure than a patient breathing normally, and that can lead to the injury that we talked about. So therefore, neuromuscular blocking agents were evaluated in 7 randomized controlled trials involving almost 1,600 patients. And the pooled analysis showed that they may decrease mortality for moderate to severe ARDS. But there was a lot of risk of bias and inconsistency, and so they said it was a low certainty of evidence. And then also there was a reduction in mortality in subgroup analysis versus deep sedation. But in terms of safety, they may increase ICU-acquired weakness. If you think about it, the patient is paralyzed for a long time, their muscles are going to get weaker. These 2 slides here show the 7 trials that were included. Again, I'm not going to go into detail about them, but I want to show you, again, the intervention arm. There were a lot more similarities in the corticosteroids in the fact that they enrolled patients who had severe ARDS and within 48 hours. And the dosing protocol was different. They used different things like cystocuronium versus vocuronium, but they all kind of had a protocol of 48 hours, no more than 48 hours of paralytics. The next recommendation deals with PEEP, and that's the last recommendation we'll talk about today. And the question is, should patients, they had 2 questions here. Should they receive higher versus lower PEEP? And should they do lung recruitment maneuvers? And we'll talk about what those are. The recommendation was, yes, they did suggest the use of higher PEEP, but they recommended against prolonged lung recruitment maneuvers. And they defined prolonged lung recruitment maneuvers as a PEEP of greater than 35 with for more than 60 seconds. So what are lung recruitment maneuvers? Lung recruitment maneuvers are basically ventilator maneuvers where you give a very high PEEP for a period of time to try to recruit alveoli. They recommended against it. However, in the 2017 guidelines, they did recommend lung recruitment maneuvers. So this is a key difference between the 2017 and 2024. But similar to the 2017 guidelines, they still recommend high PEEP versus lower PEEP. And so basically PEEP is a positive end expiratory pressure, which is the pressure at the end of expiration. It's to keep the alveoli open. And so the rationale behind high PEEP is to keep the alveoli open and recruited. But again, high PEEP can also lead to injury that we talked about. So there's a net balance that you have to be careful about in keeping the alveoli open but preventing overdistension and injury. And so the reason they recommend these recommendations now versus 2017 is because of 2 meta-analyses that were published since 2017. The first one included 18 randomized controlled trials with 4,646 participants that had moderate to severe ARDS. And they found that higher versus lower PEEP had probably reduced mortality, improved oxygenation, and increased ventilator-free days. The impact on barotrauma was uncertain. But crucially, and this is what's different since the 2017 guidelines, is higher PEEP without lung recruitment maneuvers versus higher PEEP with prolonged lung recruitment maneuvers probably increased mortality. The relative risk was 1.37. The second trial included 3 randomized controlled trials, the second meta-analysis, with 2,299 patients. They showed that higher versus lower PEEP probably improved survival and possibly increased mortality if patients had mild ARDS. So you have to be careful in high PEEP in patients with mild ARDS. And so with that in mind, this slide here shows or summarizes the key recommendations that are different and new in the 2024 guidelines. Corticosteroids, VV ECMO, neuromuscular blocking agents, and high PEEP. The population for each is here. So for corticosteroids, you want to use it for patients with a P to F ratio 300 or less. Basically, all ARDS patients may benefit from corticosteroids. But crucially, it may increase harm if you use it too late, after 14 days. VV ECMO, and I want to say about corticosteroids, like I said, the optimal regimen and dosing was not really elaborated upon, and so people should use clinical judgment for dosing of corticosteroids in ARDS. VV ECMO is recommended for patients with a P to F ratio less than 80, so very severe ARDS, pH of less than 7.25, or a PCO2 greater than 60. But there are some key considerations for VV ECMO. First of all, there are some conditions that may be associated with futility in VV ECMO. So if you have an irreversible etiology of your respiratory failure, if you have multi-organ failure, older age, a CNS hemorrhage, you may not want to use VV ECMO in these patients because it's, again, very resource heavy. The other thing is you should have tried many less invasive therapies, basically all the ones we talked about. Lung protective ventilation, proning, neuromuscular blockade, it should be initiated before you consider a patient for VV ECMO. Third is paralytics, and they're recommending them for early ARDS. That's based on the trials where recruited patients 48 hours or less since their mechanical ventilation. And with severe ARDS, P to F ratio less than 100. But again, they may have the best effect on patients who have ventilator dysynchrony. The thing is, we don't really know their effects on patients without ventilator dysynchrony. Last is high PEEP, and that's the last recommendation is, again, P to F ratio less than 200. And the other consideration is there's no optimal PEEP strategy that they commented on. So they recommended doing a PEEP or increasing PEEP for an oxygen level. So monitor the patient closely, increase the PEEP to a certain oxygen level. But the other thing is high PEEP can also cause hemodynamic compromise by increasing thoracic pressure and decreasing venous return, and that can lead to hypotension. So you have to be careful about that as well. So you could do a PEEP to an oxygen level similar to the ARDS net trial, 85 to 95%, or 88 to 95%, sorry. One more comment about fluid management in patients with ARDS. I don't know if anybody's heard the term like keep the lungs dry or dry lungs or happy lungs. That comes from one trial in 2006, which compared CVP for patients with ARDS, high CVP versus low CVP, and low CVP at decreased mechanical ventilation days, basically. And so that's where this recommendation comes from, to try to keep the patients dry. Although a lot of these patients may have shock and hypotension and require fluids, but you have to keep that in mind as well. So again, this nice graphic here illustrates all the recommendations. So a strong recommendation against prolonged recruitment maneuvers and high frequency oscillatory ventilation. Conditional recommendation in favor for steroids for all ARDS. This is mild, moderate, and severe. High PEEP for moderate to severe ARDS. VV ECMO for very severe ARDS based on the P to F ratio. Neuromuscular blockade for severe ARDS. And lung protective ventilation is recommended strongly for all patients with ARDS. Some uncertainties which I touched upon, and those may be great areas for further research. First, the optimal strategy for PEEP is uncertain. Second, there was no dosing guidelines for steroids. Third, little is known about the long-term outcomes of ECMO survivors. Some data suggests that they might have lower quality of life. Although they have decreased mortality, they might have lower quality of life compared to patients who had just mechanical ventilation and conventional ARDS management. And finally, we don't really know whether patients who are fully sedated, compliant with the vent, whether adding paralytics helps in those patients. So those would be great areas for further research. So these are my references, and this is just to show how the evidence was graded. So I would like to thank my mentor and all Dr. Debella and all my other mentors, and I'll open up the floor for questions. Thank you very much.
Thank you, Dr. Alaws. Any questions or comments? If you're viewing online, enter your question into the chat and we'll ask for you. We do have one here in the audience.
Thank you very much for this excellent presentation, Dr. Alaws. I have two questions. You said that there's definitions that are changing for ARDS in terms of non-ventilated patients, non-intubated, sorry. Coding-wise, are we going to start seeing those different names, or we just call patients ARDS and then we just subspecialize them or divide them into non-intubated or whatever?
That's a great question. The answer is I don't know. I think it would be great actually if they added it to Epic. The last time I checked, it's not in Epic, but it probably will be at some point. For now, probably safe to say ARDS and then comment on why in the text.
And second question, in terms of the PEEP, for patients who are intubated, high PEEP seems to be the favored method. What about non-invasive mechanical ventilations before they get intubated? Do we also kind of aim for higher PEEP levels for those patients?
Well, probably not, because you can only increase PEEP so much in those patients. But not sure if there's any trials that showed that higher PEEP might be beneficial in non-invasive ventilation, but that's a great question.
That was a really great presentation, Hossny. Good job. My question, I guess, with your research, did you come across any trials comparing the different vent modes like APRV, BCAC, anything?
Yeah, that's a great question. Actually, there's a lot of trials comparing the different ventilation modes. And APRV is basically prolonged lung, or basically like a lung recruitment maneuver. So I guess these guidelines would say that since this is a prolonged lung recruitment maneuver, is not to rely so much on it. But again, they didn't say it APRV because APRV is like a brand name. But like APRV is equivalent to like prolonged lung recruitment. There are other, like the high frequency oscillatory ventilation. Again, there's a recommendation against that. And that would be certain ventilator modes as well. But there's a VCAC versus PCAC. No, I don't think there's any difference.
Thank you so much, Hossny. It's a great presentation. So I have just question after the survival. You mentioned that there is a lot of lung fibrosis. What is their quality of life moving forward? Because there is a lot of damage and it's permanent scar. So.
Yeah, certainly. I mean, I think these patients that have ARDS usually require a very prolonged ICU stay. And even if they don't have fibrosis, but especially if they do, they have a lot of issues with quality of life afterwards. So they may have even after they get discharged from the ICU, they may have a lot of weakness and require a lot of physical therapy and delirium in the ICU and psychological and mental changes associated with that. So they definitely have a reduction in quality of life, especially if they have fibrosis, but even if they don't, because they were going to require a long ICU stay and then a hospital stay after that.
Thank you, Dr. Alaws.